Okay. Hi, I'm Cheryl Clark. I'm the Associate Director of Epidemiology, Equity Epidemiology and Evaluation, excuse me. I do know my name. I've been at AMCHP for about 5 years, and we're going to, my team are going to talk to you about equity in telehealth, the what, the when, and the hows of evaluation. Next slide, please. One of the things that we are hoping that we gain with this is reaching these objectives, which are, after this session, the attendees will be able to define and compare basic types of evaluation and their respective uses. Our second objective is that the attendees will be able to develop and confirm evaluation foci based on telehealth related activities, efforts, and their expected results from these efforts. The third objective is that the attendees will be able to discuss the use of the Equitable evaluation framework in the development and implementation of their evaluation process. Next slide, please. First, I want to start off by just giving kind of what folks may already know, but it's good to start off at a foundation of knowledge that we can all kind of reference. There was a study that was conducted by our good friends at HRSA, Maternal and Child Health Bureau, and the National Center for Health Statistics, along with the Census Bureau. And they were trying to find out and compare some via survey, some trends in telehealth use in 2021. As we know that telehealth skyrocketed because of it needed to, because service disruption, et cetera. So what they found out between the study period ran from April 2021 to October 2021, that 23% of the respondents to the survey had used telehealth services in some capacity in the prior 4 weeks from their response to that survey. And telehealth services are considered to be a video format or audio format, but some kind of interaction between, the client and a health provider or health facilitator. And then 20% of the respondents reported that there was a child in the household when they had those services, and that child was the recipient of those telehealth services. What they also found out that there were lower rates among folks that were uninsured. There was a lower percentage of the respondents that had used telehealth that were young adults aged 18 to 24, that the Midwest portion of the United States had lowest rates. And then conversely, there were higher rates among Medicaid recipients and Medicare beneficiaries. And then for race, among racial and ethnic groups, Black, non-Hispanic Black was 27% use, and then multi-race and other was close behind with 26. And then incomes of folks that earn less than $25,000 a year also had higher uses of telehealth services. Next slide, please. And as I stated before, we're talking about telehealth in terms of audio and visual, but there were definitely differences in how folks were accessing either audio or video telehealth services. The highest video telehealth use was among the young, and then also the incomes that were higher at 69%. And then insurance type was private insurance, and then for race, it was non-Hispanic white. The lowest video telehealth use was folks without a high school diploma. 73% of those folks did not use video. And then folks who were older, 65 or over. And then for among racial groups and ethnic groups, Black race, Asian Pacific Islander, and Latinx were around 50%. About half of them were not using video for telehealth. One of the things that we're going to talk about now that we have kind of this foundation about folks were using it, but not at the same capacity, we want to describe how we would evaluate that. So what is evaluation? Evaluation are efforts to determine, how something is working, how effective it is. But we also use evaluation to compare. Is one group, getting something, at a higher level or rate compared to another group, or even geographic regions. But all in all, it's a systematic collection and objective analysis of evidence to assess issues such as relevance, performance, value for the money spent, what is the intervention's impact and sustainability, and then also recommend ways to move forward. Next slide, please. So all about that is why to evaluate. And I think I want to ask our audience member, why would we evaluate? And I know you see the slide, but have you done any evaluations? And if so, why have you evaluated any program?
For me, I think evaluation, not large scales as this, because my main portfolio is the emergency department. But usually when we talk about evaluation, we evaluate the programs we run. We want to see the effectiveness, the outcomes of, let's say, post implementation of a program. For example, I'll give you one that that's closest to my heart. Basically, basic life support. So you teach basic life support in the department. We implement. This program I spearheaded implemented the blended learning environment. We transitioned from fully paper model to a online base mixed with, and so what happens is, after transitioning, we had to evaluate whether this new blended learning environment was effective and whether the students were gaining benefit, whether there was more, I would say, whether the outcomes of the patient was improved. And therefore, after that, when we evaluate the outcomes, we could justify that this environment we migrated to was a better way of learning for the students. So does that answer your question?
No, that was great. In fact, you did the slide for me, so thank you.
Oh, sorry.
No, yeah, that's what we wanted. So exactly, measure effectiveness, demonstrate accountability, ensure funding or sustainability, improve, or provide, new ideas for new programs or initiatives, justify why something, why are we doing this the same way? Because it works. Justify, activities or programs, and also we want to share, effective strategies and our lessons learned. It used to be that, either something, people get nervous about evaluation because it's either was seen as something works, so it doesn't, you're going to get a fail if you didn't prove something. But the lessons we learn all along the way in evaluations help feed other processes. So thank you, June. That was really cool what you just said.
Thank you. No problem.
I'll be calling on you quite
no.
often.
Okay, no problem.
Okay, so one thing that, folks, and maybe June's not one of them, but when we are talking about evaluation, sometimes people don't know where to start. And it starts with two simple questions. Number one is, whatever you're doing, what are you expecting that your participants or whoever's going to be recipient or benefit from the services or whatever event process? What are you expecting them to get from what you're doing? And then that's the first question. And then the second question is, okay, now that you've got your expectations, how are you going to measure how effective you were in achieving those expectations? So June, I think you were talking about, you were wanting to see if students were getting the benefit. You had an idea what they wanted, you want it to happen, and then now you're measuring to see if it happened or not the way you planned.
Correct. Yep, that's true.
Yeah. Next slide, please. Next slide, please. And I'll turn over to Courtney.
Great, thank you, Cheryl. So the primary types of evaluation are formative, process, and summative, which is an umbrella for outcome evaluation and impact evaluation.
Mm-hmm.
So formative evaluation, what is it? It is a process to examine contextual factors in planning and design. So some examples of things you would want to consider during this evaluation are like feasibility, relevancy, cultural appropriateness, and communications. You would use a formative evaluation when a new program or initiative is being developed, or when an existing program and initiative is being edited or adapted. Next, we have process evaluation, which can determine whether activities have been implemented as intended. You would use this periodically throughout the course of the program to ensure the program's activities and outputs are aligned with the plan and/or logic model. And on the left-hand side of the screen, we have like a little evaluation cartoon, which I hope that you think is just as funny as I think it's funny. But as you can see, there's kind of like a work plan on the chalkboard. And then in the middle, it says like, then a miracle occurs. And so the evaluator is like, I think it should be more specific instead. So good, you're laughing. So I'm glad you think.
Yeah, I can connect.
Okay, good. So we have another little cartoon here, but outcome evaluation determines the effect or change by assessing objective progress or achievement status. And you would use this when an event or activity is implemented onto subjects or in a focus area. So again, a little cartoon here. This person says, could you help me predict my outcomes? And then the other person replies, sure, evaluations keep me in business. So just a little evaluation humor to show everyone that it can be fun. So next, impact evaluation assesses effectiveness in achieving its ultimate goals. You typically use this after implementation. It could be at a milestone, at attrition, or at agreed upon measurement point. Impact may not be immediate, so it may be some time before impact can be assessed. And then we have an honorable mention of economic evaluation, which is the process to identify, measure, value, and compare the costs and consequences of actions and interventions. You use this at every point during your program, at the beginning, during, and at the end. There are also some other evaluation subtypes. So cost-benefit analysis is a way to compare the costs and benefits of an intervention where both are expressed in monetary units. Cost-effectiveness analysis is a way to examine both the cost and health outcomes of one or more interventions. So this would be used to compare one intervention to another. And then return on investment can be either economic or social. So economic return on investment assesses the performance of financial investments. It's useful for understanding the potential financial benefits of an investment from the perspective of the investor. And then social return on investment takes social, economic, and environmental factors into consideration and reflects the effectiveness of an organization's ability to translate resources into real value for the community. So funders, investors, donors, and other community stakeholders would use this to kind of communicate precisely what their financial contributions have provided. And AMCHP actually has an essential series module on return on investment that is really great. So we will make sure to provide the link to that as well. And then last but not least, we have an evaluation timeline. So I would like to note that real life processes are not likely to be as linear as this graphic. And this is subject to change based on evaluative assessments or circumstances. But ideally, formative evaluation would take place before implementation, process evaluation would take place during implementation, and then outcome and impact evaluation would take place after implementation. And before I pass it off to Michaela, I did want to pause and see if you had any questions about the different types of evaluation before we move forward.
I'm good so far. I mean, it's pretty clear. I mean, it's nice to see the linear, I mean, in the graph form, I would say, because, you know, many times in processes, like, I mean, in places like the ER, you just rush through things and you don't see a lot of this kind of just frameworks just clearly put out, but that's a very good one. Thank you.
No problem. Okay, I'll go ahead and pass it off to Michaela. Thank you.
All right, thank you so much, Courtney. So I'll be walking us through a little bit of how to start thinking about centering equity into evaluation by giving an introduction to the Equitable evaluation framework. Yeah, thanks. Next slide, right on cue, thanks. So this framework was created by the Equitable Evaluation Institute and is guided by 3 principles that provide a foundation for shifting the evaluation process from one that is defined by and perpetuates white supremacy to one that is based in participant ownership and incorporates and advances equity. Next slide, please, Courtney. Thank you. So these three guiding principles of the equitable evaluation framework are evaluation and evaluative work should be in service of equity. Within this principle is the idea that we have a moral imperative to place equity at the core of every step of the evaluation process. The second is that evaluative work can and should answer critical questions about the effect of a strategy on different populations and the underlying systemic drivers of inequity, the ways in which history and cultural context are tangled up in the structural conditions and the change initiative itself, and the ways in which historical and cultural decisions have contributed to the present conditions. And the last one is that evaluative work should be designed and implemented commensurate with the values underlying equity work, meaning the approach should be multiculturally valid and oriented toward participant ownership. Next slide, please. These three principles on this previous slide guide the equitable evaluation framework to dismantle and redefine what they refer to as the common orthodoxies of evaluation. And these orthodoxies have been identified by the Equitable Evaluation Institute into 12 distinct orthodoxies. And they define them as tightly held traditional and inequitable beliefs about evaluative practice. These are often invisible, passing off as quote unquote common sense. They are believed to be foundational and affect the undercurrents of organizational culture. Many of the current orthodoxies conflict with achieving equity, and in many cases actually reinforce inequities. Among all 12 orthodoxies, centering foundations and evaluators as experts, promoting traditional ideas of expertise, and discounting the richness of qualitative data are some common themes. Next slide, please. So continuing on with these orthodoxies, evaluations should provide generalizable lessons, as you can see in the top right box. It's a good example of how these orthodoxies do not align with equitable evaluation practices. Evaluations are often designed to provide synthesized, generalized findings that hide unique contexts, differential outcomes, and historical and structural drivers. This can lead foundations and funders towards the illusion that generalized approaches work similarly in any community or for any group. Next slide, please. So to reframe, rename, and dismantle the current underlying orthodoxies of evaluation, the Equitable Evaluation Institute calls on evaluators to approach our work in ways that center equity. This relies on a commitment to the three equitable evaluation principles: that evaluation and evaluative work should be in service of equity, that evaluative work should be designed and implemented commensurate with the values underlying equity work, and that evaluative work can and should answer critical questions about the legacies of historical and structural decisions, cultural context, and the effects of a strategy on different populations. So without working in these ways, we do risk reinforcing the inequities we wish to change. Next slide, please. So in considering ways in which we can integrate equity into evaluations and other evaluative work, we can pull on the example that Cheryl shared earlier. The National Survey Trends in Telehealth Use provides us with a cautionary example of setting priorities on the basis of absolute or unadjusted rates and percentages. So this example brings to light the importance of intersectionality and how we as evaluators can be more equitable in how we analyze and communicate evaluative data. Specifically here, we see that the interaction between demographics, such as age, race, ethnicity, income, and insurance type, will express in differing telehealth usages within populations. So the first column shows unadjusted or absolute percentages of populations that have higher percentage usage rate of telehealth services. We can see here that 6 groups had higher rates of usage, among them being non-Hispanic Black respondents and multiracial respondents, those who receive Medicaid, those who are 65 years and older, and those whose income is less than $25,000. However, after running adjusted models, or including all of these variables in one model instead of analyzing them separately, we see that in actuality, the groups with higher odds of utilizing telehealth services were respondents who self-reported as Latinx, Black, and multiracial or other, those who are in the older age groups, 25 years and older, people making less than $75,000, Medicare and Medicaid beneficiaries, and those with other insurance types. In contrast, the groups with lower adjusted odds of utilizing telehealth services were respondents who were uninsured and from the Northeast, Midwest, and South region compared to the West. So if only unadjusted columns 1 and 3 usage rates were reported, how might this impact setting telehealth priorities? First, it would under or over-report certain groups as using or not using telehealth, so suggestions or targeting certain populations might be skewed. Secondly, it erases the complex interaction that demographics have with each other, which might cause priorities and strategies to be less comprehensive. And generally, the data supporting these priorities are, although not wrong, would not capture the full picture, especially how different demographics will impact telehealth usage within populations. Okay, next slide. So here, we just have a few closing discussion questions. I'm going to open it up to also my AMCHP colleagues to jump in here.